All right, so we're gonna end with some alternative interventions and then some mechanisms. So I just want to give you some context for, okay, how are other things? Like we just talked about how exercise maybe directly translates to weight loss. How do other interventions? This is the calorie study, and you can see, sorry, let me get my laser pointer, percent weight change over here, right? And then time in months. So you can see that with this study, we saw on average maybe about 10% weight loss. Um, and then in this other, also this was a calorie-based study. I have the details in the slide notes if you want. But again, looking like we're leveling out right about 9% of body weight loss. Um, with these types of interventions. And again, you can go in the Diet Fit study specifically focused on composition of diets, and it compared two different diets. It compared a low-fat uh, diet, a low-fat healthy diet, and then a low-fat healthy carb or a low-carb healthy diet, and looked at weight changes, and they saw no difference between the diets. And that's what we see over here as well. Just that regardless of the diet type, so this was carbs, fat, or no, carbs, protein, fat in that order. So 65% carbs, 15% protein, 40% fat. Here 55%, 25%, 20%, 45, 15, 40, right? And then 35, 25, 40. So lots of different diet compositions. And what they found is that right? You see all this overlap in terms of where those dots lined up, right? That across 24 months, all of the different diet groups lost weight. All of them also only lost moderate weight in this particular category or in this particular study, right? But it didn't matter which diet they were on, similar to the Diet Fit study. So you can lose weight with calorie restriction, and it doesn't seem to matter what the composition of that diet is. I will say the one caveat to that is that a lot of diets focus on low carbohydrate or low fat diets. If you focus instead on high protein diets, it looks like there's some moderate differences. So we do see that compared to like a standard protein diet, a high protein diet did result in slightly more, less than 1 kilogram difference, but slightly more weight loss. It also resulted in slightly greater decreases in fat mass and slightly greater increases in fat-free mass. So, if you are going to focus on one thing for dietary interventions, it would probably be high protein and then total caloric intake, because total caloric intake has to be low, right? Energy intake has to be lower than energy expenditure to see weight loss at all. And if the composition of that diet is a high protein diet, we might have slightly better results there. Um, so this is just like a fun quote that I wanted you all to consider and maybe comment on that Frank Greenway made. Pretty like a prominent physician in the research world. He works on clinical trials, but said that to maintain weight loss, individuals must adhere to behaviors that counteract physiological adaptations and other factors favoring weight regain. It is difficult to overcome physiology with behavior. Weight loss medications and surgery change the physiology of our body weight regulation and are the best chance for long-term success. So I want you to decide whether or not you agree with the statement that it's difficult to overcome physiology with behavior and why or why not. You can also just comment on whether or not you agree or disagree with the quote as a whole, but I thought it was a very thought-provoking statement coming from someone who works in this field. So this isn't just an MD who does primary care. This is an MD who does clinical trial research on obesity. Okay, so besides nutrition, right, or diet, right, those are behavioral interventions. We also have pharmacologic interventions. And when we look at this study looked at placebo-subtracted weight loss. So, right, we know that whenever there's any intervention, there is a placebo effect. Okay, so we would expect some weight loss. When we compare weight loss from exercise, right, we're looking at 3%, right? Which is exactly what we calculated for me in that volume uh, calculation we did earlier, right? About 3% of weight could be lost from exercise. When we compare what that to pharmacologic interventions, right? These are older interventions, but phentermine is sometimes still used. I don't think orlistat is used anymore. Liraglutide was our first GLP-1 drug, I believe, on the market, and it was released in 2010. Um, Here I have in the slide notes for you. The liraglutide half-life is 13 hours and is injected daily. Okay. So it's a GLP-1 drug, but when you compare that to a semaglutide like Ozempic and Wegovy, which are pretty popular right now, the half-life for those is 7 days. Okay. So really different. You're injecting once per week as opposed to injecting daily. And even if you're injecting daily, the half-life is 13 hours. So that's really only lasting you half of the day, whereas the GLP-1 is lasting the semaglutide is lasting the entire week. Okay, so pretty different. And then you compare that to a tirzepatide, which is a GLP-1 and GIP agonist. Um, so slightly different, but slightly greater weight loss, right? So we see with tirzepatides, average weight loss is above 16%. Semaglutides looks like maybe around 10%. I'm going to show you a little bit more data on that. And we compare that to exercise-related weight loss, right? Significant difference between those two. So this is data looking at semaglutides and tirzepatides specifically, right? And again, what we see is about a 20% weight loss with tirzepatides at 10 milligrams and semaglutides at about 12 to 15% with 2.4 milligrams of injection. So really, really different. I have some really fun slide notes here for you if you want. One of the common things that I hear is, okay, well, but they're losing so much lean mass. It's true, they're losing lean mass, but almost actually every study that I have looked at, and they're in the slide notes for you, shows that at the most they're losing it in a 1-to-1 ratio. So they're losing about 50% fat mass, 50% lean tissue. Um, in some studies, and especially there's some really interesting studies that combine different drugs. So one of the drugs that is used in some of these studies is cagrilintide. And in combination with a semaglutide, it looks like actually that preserves lean mass while losing fat mass. So actually the outcomes in that study were really great. There are some studies ongoing right now that are looking at resistance training when combined with a GLP-1 agonist drug. Um, anyway, some pretty interesting stuff going on, but I just wanted to comment on what the changes in body composition might also be. This is such fun data, you guys. So I just put this here mostly for you. But looking at mean weight change with different dosings, right? It looks like there's a pretty clear dose response relationship for how much GLP-1 drug you inject yourself with. People are experiencing side effects, right? As a result of these drugs. So nausea, diarrhea, and constipation are the most common, experienced by as high as sometimes 30% of the population. Um, you do see significant drops in weight with a variety of different doses. Note that you do see, right, some placebo weight loss as well, an average of 3%. So again, placebos are really helpful and important. I bring this up partly because I see this a lot with like supplements, right? People take a supplement and they believe that it's going to result in weight loss. And because of that, they actually do see weight loss and maybe even on the edge of clinically significant weight loss that you might be able to see with exercise. So I might think, oh, yeah, that's totally working, when in reality, it's actually the result of a placebo effect. I'm very data driven. So when people claim this supplement does this thing, I say, okay, well, show me the data. And how efficacious something is, right? So we have talked about how, right, some people lose lots of weight with exercise. Some people lose no weight with exercise. Here with these drugs, this is the participants who met the goal of greater than or equal to 5% weight loss, really, really high percentages. So 96% of individuals were meeting greater than or equal to 5% weight loss. So um, we're not seeing a lot of non-responders to these drug interventions. Um, This is actually data on retatratides, which have not been released yet. So this is human clinical trials. I would expect retatratides to be coming out soon. But this is acting on three different receptors as opposed to two. And mostly I brought this up because of this particular finding. It's really difficult to get 100% of your participants to do anything. But 100% of their participants who were taking retatratides at 8 mg or higher achieved greater than or equal to 5% weight loss. It's really tough to do. So I saw this and I was like, whoa, that's wild. Anyway, something to consider, right, is how effective are these drugs for a lot of people, and how much variability is there between people? And looks like there's not a lot. Um, Also, participants who are severely obese, so greater than 35 BMI, actually had experienced greater amounts of weight loss compared to individuals who had a BMI of less than 35. So again, something that we would actually hope to see in these studies. I think I've already gone over sort of semaglutide stuff, so I'm not gonna spend too much time here. Oh, this is why I had this study in here. Okay, sorry, I forgot. I am gonna go over this real quick. This was a study that showed that there was no difference between weight loss experienced as a result of semaglutide injection and low carb diet. The problem is that this was a 3 month study. People self-selected into a group, so there was no randomization, right? But sometimes you see stuff like this again, coming back to the online piece, right? Where people say, no, you can achieve just as much weight loss if you just diet. And they would point to a study like this and say that that's true. Yeah, well, this study had no randomization and it was for 3 months. Whereas if we look back at these studies went on for this was 48 weeks, right? Which is a year. Okay. This study went on for 72 weeks, almost 2 years. Okay. These studies went on for 2 years, right? So when I see, okay, well, yeah, that was a 3 month study and there was no randomization, I'm not going to believe it very much. But a lot of people won't look into anything. They just see these figures and they say, wow, that looks so impressive, right? And what they don't know is, okay, well, sorry, those were actually figures from the semaglutide study. They're not figures from this study because I didn't want to show them because I don't believe that it's high quality data. In any case, I want you to be productively skeptical. When someone makes a claim that doesn't align with, the rest of science, right? That coherence piece, if we looked at Hill's 9 criteria for causation, you should second guess it, right? And it's not even that they're saying there's no data to support it. They're saying there is data. Yeah, but what is the quality of that data? Anyway, I just think it's helpful to think about. Last thing we're going to cover for interventions is bariatric surgery. Bariatric surgery has the greatest amount of weight loss when we compare to diet, exercise, and pharmacologic interventions. So here you can see that the average percent body weight loss, you're looking at like 30%, which is pretty typical. And then this is just a great slide full of a ton of information. So I cited an AMA format here so you could see it, how I do it, and you can go into the slide notes and pull all of these citations. But then what about weight regain, right? We just spent a bunch of time talking about weight loss. What about weight regain? So when we look at lifestyle, diet, and exercise interventions, we see that people regain about 50% of the weight they lost within 2 years, and by 5 years, about 80% is typically regained. And full regain can happen within a year. And that happens for a variety of different reasons. You can go through here and take a look at what I have written down and what I cited. With pharmacologic interventions, right, I looked at semaglutides and tirzepatides. Semaglutides, after a year and a half, people had about 17% weight loss. Over a year without the drug, they gained 11.6% of their 17% back. So they still a year later had a 5.6% weight loss, which is clinically significant weight loss. Um, uh, 2 years after the intervention. With the tirzepatides, after 9 months, you had 21% weight loss. Those who continued the tirzepatide after 9 months, they lost another 5.5%. So 26% weight loss by 2 years. Those who were switched at 9 months to a placebo, regained 14% by 2 years. So, but again, still maintaining 7% weight loss, which is clinically significant. For bariatric surgery, weight loss typically plateaus after about 1 to 2 years. So there are two different types, by the way. So you have a gastric sleeve, which is just sort of compressing your stomach, and then you have a gastric bypass, which is literally just you take essentially your esophagus and you plug it into your small intestine and you bypass your stomach completely, essentially. It's pretty wild. So outcomes differ based on the bariatric surgery that you use, but in any case, typically weight loss plateaus at about 1 to 2 years, with about 10% regain occurring in 23% of people after about 3 years, and then in 72% of people after 5 years. So what this is saying is that they regained 10% of the weight that they lost in 5 years. So 72% of people did that. In terms of regaining 15%, about 50% by year 5 did. So significantly less. And you can see, okay, they're only regaining 15% of the total weight that they lost. So they are still maintaining 75% of the weight that they lost, which for these individuals, right, if we go back to the previous slide, they're losing like 30% of their total weight. So I don't know, do the math, but they're still maintaining like 20% weight loss from baseline, which is huge. So at 5 years, the percent total weight loss is still, oh, there you go, 22 to 26%. So still maintaining huge amounts of weight loss 5 years later. So anyway, helpful to think about, okay, sure, can we lose weight with a given intervention, which I think I've hopefully covered pretty well? Can we maintain that weight loss is really what this weight regain piece is about. And it should help you sort of shape some of your thoughts and also consider what you might recommend in the future. So to summarize, exercise can elicit weight loss, though the effects are modest. Higher volumes improve weight loss and maintenance. Outcomes are heterogeneous, right? And regain is likely. With nutrition, caloric restriction is necessary for weight loss. The composition may affect the outcome, right? We talked about increased protein, satiety and adherence, and a high percentage of regain is likely. For pharmacologic interventions, they do alter your physiology. A high percentage of regain is likely. However, clinically significant weight loss may persist. I say may because it did persist in those studies, right? But there's still studies that are looking at like 2 years as opposed to what about 5 years? What about 10 years, right? So we're still waiting for some of that data to come out. For bariatric surgery, it's the largest amount of weight loss and typically the most durable. So there's a very high likelihood that clinically significant weight loss will be maintained. And again, we have data at 5 years out that is still showing clinically significant weight loss. There may even be data that's longer. I just didn't find it. So as a key point, exercise alone has modest effects, but as part of a combined strategy, it improves health, supports weight maintenance, and reduces disease risk. And I will say, I didn't present this data, but the data is really clear that when you combine multiple different interventions, and that includes things like behavioral therapy, so actually talking with a counselor as part of one of these strategies, that when you combine multiple of these strategies, they become more effective. So even if I just combined exercise and diet, right, more effective. If I combined pharmacologic intervention and exercise, more effective, or pharmacologic intervention and nutrition intervention, more effective, right? All of them are more effective if you are trying to hit multiple different interventions. So really briefly, I'm not going to spend too much time here, but how does exercise then contribute to health outcomes related to overweight and obesity? So what are the mechanisms involved? And we've already gone over that a little bit, which is why I'm going to be brief here. But essentially, we have improved energy balance, right, with intake and output being better coupled, right? So that's that hunger satiety cues, that appetite signaling. We have that physical activity is anti-inflammatory. You see increased mitochondrial efficiency and decreased reactive oxygen species, which we'll talk about a little bit more later in the semester. You have improved vascular function, so angiogenesis, you literally sprout new blood vessels. With exercise, you also see increased nitric oxide, which also helps with vasodilation of your blood vessels, so maybe decreasing risk for hypertension here. We see improved lipid handling, so increased HDL with exercise, increased uptake and use of lipids, so decreased dyslipidemia and decreased visceral fat stores. And then we also see improved glucose management, so increased uptake and use of carbohydrates, decreased liver glucose, and cholesterol production, right? So if you think back to when we were talking about that ectopic fat storage resulted in the liver literally producing more glucose, therefore that ending up in the bloodstream. We also see increased insulin sensitivity, which is the result typically of increased GLUT4 activity. So GLUT4 does respond to insulin, but it also responds to exercise, which then helps to pull glucose out of the bloodstream. So that's your improved insulin sensitivity piece. Okay. Just a quick reminder on this slide, right? Where does then physical activity fit in here? We could see it happening with appetite regulation on the energy intake side. We could see it slightly improving energy expenditure here. We could see it maybe shifting some of that white adipose tissue to beige or brown adipose tissue. We actually see improved ability to handle, right? I said decreased reactive oxygen species, but you see decreased inflammation. So decreased release of TNF alpha and IL-6. We see decreased visceral fat independent of changes in weight, right? We see, right, I just talked about decreased liver production of glucose, right? So I'd see decreased then insulin resistance, right? We actually see also increased leptin sensitivity with exercise as well. So exercise is involved in all of this. Again, we did sort of just cover this piece. We're going to talk more next week, well, in the following weeks about other mechanisms. Particularly, we'll hit on dyslipidemia and insulin resistance more, but today we really hit these three pretty hard. So prepping us for next week, we're going to jump into type 2 diabetes, but obesity enlarges those fat cells, which then increases insulin resistance, which can cause type 2 diabetes. Type 2 diabetes can increase appetite, which leads to overeating, which then further contributes to the obesity, right? So this can be sort of a vicious cycle. So a final summary, obesity is very common and it's costly, and it may be more impacted by visceral adipose tissue in that waist circumference piece, right, than by weight. Um, you have chronic energy surplus. I actually just went over this, so I'm not going to go over this again, but that's there for you. Exercise doesn't just result in weight loss, and in fact, results in moderate weight loss anyway, or modest, relatively low levels, but it does improve insulin sensitivity, lipid handling, mitochondrial function, fitness, and inflammation. With weight loss reality, exercise helps, but it's low. Higher volumes support loss and maintenance. Outcomes do vary according to appetite regulation, NEAT, and metabolic adaptations. So for comprehensive care, nutrition is foundational. Pharmacotherapy and bariatric surgery modify physiology and then improve the durability or the sustainability of weight loss. So the key takeaway would be that exercise is a disease-modifying therapy with a broader physiologic-aware treatment plan. It's not just a tool for weight loss. Okay. All right. Closing reflection. Having listened to all of this, which label do you think fits obesity best for you? A disease, is it a disease, a risk factor, or a phenotype? Which one would you choose and why? In 2 to 3 sentences, just a brief view into your head, maybe reference some of the things that we talked about during lecture. If the questions you generated at the start of the lecture were not answered, post them here, and that may change what we talk about in class, right? That may change what I discuss in the future. So hopefully we've answered some of that. And here we go on, I would take a little break, but here's your research article specific considerations. Okay, a couple of things I want you to consider when you're reading the article. So first off is at one point it talks about BMI groups, and it groups a high BMI category and a low BMI category. The high BMI category is 27 to 54 kilograms per meter squared. Okay, that is this as if I took someone who was 5 feet 4 inches and they weighed anywhere between 160 and 315 pounds. Okay, that is a massive range. I don't know anyone who would think that somebody who's 5'4" and 160 pounds has the same physiologic processes or is at the same point in that physiologic process as somebody who is 5'4" and weighs 315 pounds. Those are clearly really different things. The average weight, just for the record, and this is very rough data, but the average weight for a female in the United States is 5 foot, or the average height is 5'4", and the average weight is 170.8 pounds. So that just gives you some context. So the average female is overweight. Similarly, for males, the average height is 5'9", and the average weight is 199 pounds. So again, overweight, but not actually obese yet. But again, the range for someone who's 5'9" is anywhere between 185 pounds and 370 pounds. Okay, so it's just helpful to look at these. I'm not discounting their findings or their associations. That's the other side of a bad sort of consumption of research literature, right? We shouldn't discount people's findings because of their limitations. We just need to understand that there were limitations. Okay, and that is one of them here. Particularly when we consider that clinically meaningful weight loss, so not significant, not statistically significant, but clinically significant, meaning we actually do see improvements in health, maybe decreases in mortality risk, happen at low levels of weight loss, so 5 to 12 pounds. So the fact that this study sort of groups people who have, I guess I didn't do the math, something like a 150-pound difference into the same category when we can see improvements in health with 5 to 12 pounds of weight loss seems incorrect to me. Okay. And we see that happening in a dose response fashion. So particularly with type 2 diabetes. So however much weight you lose, we see that level of improvement in your mortality risk is all that's suggesting. Okay. Oh, the article specifically talks about that level of decreased risk for type 2 diabetes or for even remission of type 2 diabetes. Okay. At one point, the article also says something about an unchanged fat-free mass or unchanged muscle mass. I just want to mention so that when you're reading articles, you start to think about this as well. Unchanged does not mean that things didn't shift. Generally speaking, with age, so I think in this case, it was a 3-year longitudinal study. With age, we see decreased fat-free mass. Okay. That's a negative. It's associated with negative health outcomes. Okay. So if I see it unchanged across time, that's actually a win. Okay. So oftentimes we think, oh, well, then that exercise intervention did nothing because it's the same values. No, that means that the exercise intervention really helped to maintain lean muscle tissue or lean tissue, despite the fact that we'd typically see that drop off with age. Okay, so don't think that unchanged is some null finding or that nothing important happened. Sometimes null is really good. And then also when you're looking at the physical activity piece of the article, I want you to consider, what about FitVP? Did they address the frequency? Is it important? And they do address frequency at least at one point in this article. So pay attention to what that is. Do they address intensity? Do they address volume? Do they address time, right? Sometimes we get in the habit of saying, well, exercise is just good for you. And maybe it is, but it is still helpful for people to understand, okay, but what type of exercise should I do? How much should I do? How intense does it need to be? Do I need to progress it, or can I see the same benefit across time with this certain amount, right? So all questions that I want you to be thinking about when you read the article. Okay, time to jump into the article, and I will see you in class on Thursday.